everyone. My name is Sandeep Nathan. I'm a professor of medicine at the University of Chicago Medical Center. I'm also an associate editor for SCAI, and it's my pleasure on behalf of SCAI and Dr. Alexander Lansky, the editor-in-chief, to welcome you to another conversation in interventional cardiology. Today, we'll be discussing a paper titled Blueprint for Building and Sustaining a Cardiogenic Shock Program, Quality Survey of 12 U.S. programs. And I'm joined by several of the co-authors from this important paper, Dr. Raymond Yau, who's the Cardiogenic Shock Program Director at the Heart Hospital of New Mexico in Albuquerque. Welcome, Raymond. Dr. Barbara Basir from the Division of Cardiovascular Diseases at the Henry Ford Hospital in Detroit, Michigan. Welcome. Dr. Allison Dupont, interventional cardiologist, the medical director of the CCU and ECMO program at Northside Hospital Heart Institute in Atlanta, Georgia. Welcome, Allison. And of course, Dr. Alexander Truesdell, interventional cardiologist and CSU attending at the Virginia Heart and Inova Heart and Vascular Center in Fairfax, Virginia. Welcome all. And thank you for joining me. I think we'll sort of kick this off with a presentation by Dr. Yau, who'll take us through the most important points in the paper, and then we'll open it up for some discussion. Turned over to you, Raymond.
This is our paper titled Blueprint for Building and Sustaining a Cardiogenic Shock Program, qualitative survey of 12 U.S. programs. So let's review what we've learned about cardiogenic shock in the past 10 years. We know that cardiogenic shock still has high morbidity and mortality despite all our recent advances. The incidence of cardiogenic shock is actually increasing, and it's driven primarily by heart failure cardiogenic shock patients. Multiple registries and SCAI staging system has really advanced our understanding of cardiogenic shock. Now we understand that there's different phenotypes and different etiologies, yet care and treatment still varies quite substantially. We finally had our first randomized controlled trial showing positive results for patients with acute MI and cardiogenic shock, and that was a danger shock trial. And we're starting to understand that cardiogenic shock is a time-sensitive condition. Multidisciplinary teams have been noted in small studies to improve care for patients in cardiogenic shock and their outcomes. Late detection, variations in care, and underutilization of hemodynamics and MCS results in poor outcomes, and hopefully cardiogenic shock teams and protocols may help mitigate and improve outcomes for these patients. Despite multiple registries, conferences advocating for cardiogenic shock programs, there's actually little practical guidance about how one goes about starting a cardiogenic shock program. This is what inspired us and me and my co-authors to really write about this topic, about how to create and sustain a cardiogenic shock program. What we did was we invited 12 institutions, all in different types of practice settings, both in academic and non-academic and private practice, and employed models across the United States. We performed, those institutions performed a 1-hour interview talking about cardiogenic shock development and cardiogenic shock program development. And we, at the end, reviewed the data. What was very surprising when interviewing these institutions that they all had very similar challenges and barriers developing a cardiogenic shock program. So what we did after our survey was synthesize a simple process where one can start a cardiogenic shock program. What we came up with was 7 common steps. The first is to measure baseline outcomes, meaning assess your current institution's state of cardiogenic shock care. Number 2 is identify champions, those who are going to be on your shock team, to advocate and perform the necessary duties and treatment required to manage cardiogenic shock patients. Develop protocols, change organization. This means, how do we get buy-in from other service lines? How do we get buy-in from administrators? Another essential component is educating those around us about cardiogenic shock, EMS, everyone who takes care of cardiogenic shock patients. And lastly, get expert consultation. You don't have to do commit to this process of starting a cardiogenic shock program alone. There's those like us who have started cardiogenic shock programs willing to able to help. There's also conferences such as SCAI-Shock, which also advocates and has a cardiogenic shock program building session. And lastly, it's about quality. Quality is a very essential component of cardiogenic shock, maintain a cardiogenic shock program. In addition, we also provided cardiogenic shock programs, protocols that are utilized by these 12 institutions. But lastly, what we found is that cardiogenic shock programs, in our experience, really improve outcomes. We know that they're vital to this time-sensitive condition, and hopefully we also want to advocate and promote the development of cardiogenic shock teams and programs, because we know that cardiogenic shock has a very high mortality. Patients with cardiogenic shock should be treated like STEMI patients with rapid identification, early triaging, and appropriate therapy. Thanks, Sandeep.
Well, that was terrific. Thank you for the overview, and I think we'll open it up for a few questions. Raymond, let me ask you first, who are the types of providers who must be involved to start a cardiogenic shock program? I think it's nice if you're at a level 1 center to have all the support in the world. Everybody's opinion, I think, helps. But what would you say is sort of the minimum complement of types of providers to start a program, and then who should be on the call once you actually get up and going?
I think the basics. Majority of these patients are going to come through the cath lab. So any personnel required to go to the cath lab is a fundamental. So in our institution, we are a very small hospital, approximately 50 beds. And in our cardiogenic shock calls, it's those immediately managing the patient. That is the ICU team, which could be a ICU attending and a mid-level provider, and it's the interventional cardiologists who are initially triaging these focus calls.
So at our institution, it's primarily interventional cardiology and critical care. So I think, Ray, you made a good point in stating that we are all very conditioned to get STEMI patients to the lab quickly, get their artery open. What many people are not conditioned to do is to treat cardiogenic shock in a timely manner. And that's why the mortality is so high, is it's not recognized in a timely manner. It's not treated efficiently. And so what we had created was we basically set up a transfer line, we call it, and that allows a one call does it all type of situation. So you can call the one number and the transfer line can connect you with whoever you need to speak with. And that's generally interventional cardiology plus or minus critical care. So we have a big hospital system with 5 hospitals, and all of these patients are sent over from our satellite hospitals into our tertiary care, and that's all done through this one call. The same line that is for STEMI patients, we also use for cardiogenic shock, PE, and ECMO.
Alex and Bobber, you've done tremendous work in this space. Any other insights that you can offer, both as folks who are invested in cardiogenic shock and also as co-authors of this paper? Do you do it differently at your institutions?
Well, I can just maybe add that, you don't have to have, advanced heart failure and transplant and every single hemodynamic support device to run a shock team. I think, Ray should be extremely proud of what he's helped his institution accomplish, which is that, they can get really quality outcomes for patients in cardiogenic shock with even limited resources in a community-based 50-bed hospital. I mean, Ray has put in Lava ECMO and Impella and, all of these other devices that are adjunctive treatments for cardiogenic shock care. He's collaborated closely with larger institutions within the area to be able to expedite transfers. And, I'm sure Ray can speak about it better than I can, but it's not even just transferring to one hospital, because all of us know that the there's a bed crunch, an ICU crunch, and so there's multiple team members that he can call at different institutions. And I think ultimately, when we talk about how to make cardiogenic shock care better, we have to do it in this way. It's a grassroots, get your hands dirty, be involved in patient care, have the courtesy and openness to be able to call physicians throughout your community to do what's best for our patients.
Alex, you and your colleagues published an important paper a couple of years ago with the ANOVA experience and how outcomes changed after implementation of a cardiogenic shock program. I think, Ray made an important point that you have to sort of know where you're starting. How often should you sort of benchmark your own institution once you get underway?
Yeah, I think that's a great question. So I think one, and Ray brought this out too, is don't start from scratch. So part of, step back, this is all very personal to everyone here. I mean, what Allison has built, what Barbara has built, what Ray has built. Ray and I first met each other because he reached out and said, tell me about your program. I did a Zoom talk to his whole program. After a year, he was so excited about this QA project for his community, for his neighbors. And he said, we got to write a paper. And he reached out to everyone whose brains he had picked. And he spearheaded this project that you now see as a paper. So now I'll get to your question, but I think that was really important, for people to understand. So I think every situation is going to be different. So you have to look at where are we and who are we as an institution and where do we want to go? And that's going to look different. And who are our friends to our right and left, above and below? And for the benchmarking thing, there's all kinds of national benchmarks. I'll leave that to someone else. But I think early on, I think every couple weeks and every month, you really have to look at, say, like, what's our bleeding? What's our survival? What's our complications? What's our adherence to our protocols? What is our one call line? Is it really one call? And I think, that's really essential in the beginning. We did that on every 2 weeks in the beginning, and we still do that. And then I think probably at every year mark to really do a comprehensive relook at everything, because you may not be as awesome as you think, or you may be better, but you won't know unless you dig into it.
I want to echo what Alex said. Now my shock program is approximately 3 years now, and we started where ANOVA started, about 50% survival. But every year since we initiated our shock team and shock program, in survival across all stages of shock improved, and we're seeing the same outcomes as ANOVA has now. So that I really have to give credit to ANOVA and Alex's work in this space.
So, I have a sort of a related question. Many institutions operate independently, but also as part of a network. Is this sort of a call to action, in your opinion, Ray, for every hospital to have some semblance of a shock program, or is it more important to be part of a network and weigh in to sort of the mothership? I think certainly when there's issues of transfer, that's one thing, but do you sort of tap into the wisdom of the overall group, or have your own program? No, it's a little bit of a difficult question to answer.
I think it has to start with grassroots. From a society or everyone treating cardiogenic shock, we know outcomes in these patients is poor. I mean, mortality extends to 50 to 90% at least. And why is there such a disconnect or fragmented care for these types of patients? We all should be treating these patients immediately, identifying them early, just like STEMI patients. So I think it's a challenge to start a cardiogenic shock program, but you're right, Sandeep. It's a really difficult question to ask on how do we do this, but it all starts basic. We have to decide, do we want to alter the trajectory and outcomes of these patients? And then maybe later, as more evidence, like I said, randomized trials in this are very difficult to perform, but maybe as we gather more knowledge and more evidence that the standard of care may be, close within our grasp.
That's great. Do you have anything else to add, Barbara or Allison?
I would just add, it requires that you have a champion, right? So each of our institutions had champions, and not every hospital has that, but it doesn't have to be an interventional cardiologist. You know, there can be heart failure champions. There's places where the heart failure team is basically, or excuse me, the shock team is basically the heart failure team and nobody else. But whether it's a physician champion with cardiology or emergency department, there just has to be someone who's willing to champion this, because it is a lot of work. It requires convincing of administration that it's needed. And that's where collecting your initial data to show them where there's improvements that need to be made is important. But that's the only thing I would add, Sandeep.
And I think that, what Ray did so nicely within the manuscript was he basically shared, that we all do things differently. There's a different system in each of the hospitals, but where he kind of unified all of our experiences were with these themes. And these themes are best practices that institutions really need to look at to be able to help solve these problems that all of us experience as we're building these programs. And so I think really it does function as a really fantastic resource for those who are starting shock programs.
So thank you for that, Barbara. In the few minutes that we have remaining, I'm going to touch on one of the hot button issues. Now that we have danger shock, what do we actually do with danger shock? Because, on the face of it, we're all very excited to finally have a positive trial in this space, and not just marginally positive, a lot positive. On the other hand, this is 10.5 years in the making, and there's been some secular trends in the way the devices work, the devices are used, and the implementation of hemodynamics and so forth. So I think for level 1 and level 2 centers that are capable of successfully and safely implanting mechanical circulatory support, would you say that having a shock program is almost mandatory? And do you think that there has to be sort of a group decision-making model for MCS or no?
I say yes. I mean, I think the clearest example, if you look at what we're building, is the trauma model. So you could say all doctors are smart, all surgeons are smart, all emergency medicine, all intensivists. So then why do we certify trauma centers? Why do we have protocols? Why do we have, so I think that kind of answers the question. And I think we should all have shock teams. Now, where you plug and play what your capabilities, but we have to, just like a trauma center, people don't fight over marketing about those patients. They collaborate as part of a system for the community to keep more people alive and well in the community. And I think that's the same way we should look at the shock team. Rather, every center every hospital should have a team, but that will be a different team. But they should also know who they accept patients from, who they send patients to, and you have to look yourself in the mirror. So you may hurt people with MCS at one center. You may help people at another center. The biggest thing is not what your center does, but does the patient, wherever they live, get the care that they need, so that we can live anywhere we want and get the, try ideally in a perfect Pollyanna world, get the same level of care.
I think danger shock was really about getting to the scientific truth. And that was really hard to do, right? It took 10 years to be able to get the right patient population and phenotype to be able to demonstrate that you just needed a number needed to treat of 8 patients to be able to save 1 life with the use of early hemodynamic support devices. And so I think ultimately it should be standard of care and best practice to use a microaxial flow pump in STEMI shock. And I think that, what we're ideally doing with all of the different initiatives in our hospitals and cardiogenic shock systems of care is to try to be able to get to the next step, to really be able to kind of protocolize that approach, do it in an algorithm, to be able to escalate, to be able to wean, to be able to transfer, and to be able to create the system of care that's needed when using these support devices. And I honestly feel really strongly that the shock initiative was this transformative way of being able to implement what we've learned in danger shock, which is that the use of microaxial flow pumps helps patients in STEMI.
Allison or Ray, any final words?
Yeah. And when it comes to danger, I think what's most important really is that we do it safely, right? So that we utilize mechanical circulatory support in the safest manner possible. And while it's important that we get access to these devices universally, essentially, as Alex was saying, we want every patient, no matter where they live, to have access to these devices. It's incredibly important that it's done the correct way and that it's done safely, because we can easily hurt patients. So it really has to be done in a systematic manner, with a lot of caution. And that's why, meetings like SCAI Shock are so important, to come and learn how to safely do this, and how to create a shock program so that you have a place for your patients to go after you place these devices, because there's more to just placing the device. There's taking care of the patient afterwards that is even bigger challenge.
I think where we're at now is how, when balloon angioplasty first came out for STEMI, we didn't have systems of care for STEMI back then. We were just understanding this technology and the benefits for our patients. And I think that's where we're at, where cardiogenic shock patients. We here, I think everyone on this panel agrees that we need systems of care for cardiogenic shock patients.
Okay, I think we're just about at time. That's a fantastic conversation. Thank you all for joining, and thank you for this important paper and publishing it in SCAI.